الصوت واضح لكم إن شاء الله؟ الصوت واضح يا دكتورة؟ السلام عليكم. الصوت واضح؟
ايوه نعم واضح.
وعليكم السلام. الصوت واضح.
طيب.
الصوت واضح يا دكتور اسامه، مرحبا بك.
اهلين دكتور رداب، كيف حالك؟ ايش اخبارك؟
ايش اخبارك؟ كيف صحتك؟ يا
الله
جماعه
يسلمك.
انتم ذكرتوا معلومه خطا، انه اسامه ده this is not the first time. اياديه البيضاء تمتد لاخوانه، يعني دي هابت، ربنا يجازي عليها. شكرا لك يا اسامه.
لا بالعكس دكتور رداب، ان شاء الله.
Internal examiner few times in Sudan.
الله يرضى عليكم. طبعا I think this session is scheduled for 1 hour. We may not be able, so if you would like to divide it into another session, I don't mind, because the question is 61 questions, so I think it will be impossible to discuss 1 minute each question, but we'll try our best. But I think I was looking for the result. I wasn't sure that the exam was really hard to the others, or they might not have time enough to answer the questions. But can I have the next slide, the first question? Okay, so the first question is saying, which of the following is not a stated complication of the intrascalene block? Now, intrascalene block is among any other regional block. My always advise to the resident is to keep update themselves about the complication, because this is a very hot topic and the changes on the complication is changing dramatically, especially if the question is saying to you the most common complication, because those are changing periodically. So when you're asking yourself, intrascalene block, so which segment of the nerve root at the brachial plexus you are blocking? So I think that's the key point. And the other key point to answer the question is to know the anatomy. And if you don't know the anatomy very well, you will not be able to answer this question easily. If you know the anatomy and the neuroanatomy, I think the answer should not take from you more than 10 seconds. So phrenic nerve palsy, generalized seizures in pneumothorax is not surprising. Ipsilateral C8 neuritis, it's extremely uncommon, and I don't recall any case report of that to happen. Now, the question is always coming to you is about the phrenic nerve palsy. So you might get a questions asking about the phrenic nerve palsy, whether it's bilateral or ipsilateral. The common is ipsilateral, but there's some reported cases of unknown how does the spread of the local anesthetic to happen to have a bilateral phrenic nerve palsy. Generalized seizures, obviously, if it is intravascular injection by an adventure happen, and pneumothorax also because the apex of the lungs are very close to the brachial plexus. So if the needle by a mistake went too deep, so it might puncture the pleura and causing pneumothorax. Next question. Which statement regarding motor evoked potential monitoring is true? Now, to answer this, first of all, you need to know again the definition of the motor evoked potential. What are the type of the motor evoked potential we have for monitoring? Which cases that it is require motor evoked potential? This is by far most an advanced neuroanesthesia question, but if you look at carefully to the options of the answer, it's basically is asking very basic neuroanatomy. So it's assessed the descending motor pathways. It has nothing to deal with the ascending. It has actually Option C, if you look at carefully, you will notice that the volatile anesthetic has an impact. They are very sensitive. They are not listened to. They are very sensitive to volatile anesthetic. Ischemia to the spinal cord or to the motor cortex. If it's happened, it will be affected by the evoked potential. So it has nothing to deal with a neuromuscular blocking agent. It has nothing to deal with it at all, neither improved or worsening. There is nothing to do with that. What I want you to know about it, this monitoring devices are extremely helpful in cerebral aneurysm and in the brain tumor if you have it. Next slide. Which of the following is the cardiovascular complication of scleroderma or systemic sclerosis? Now, as a rule of thumb, any connective tissue disease with anesthesia, if you want to remember cardiovascular complication, always remember valvular heart diseases, i.e. Mitral regurg, bicuspid regurg, by far most, and also pulmonary regurg or pulmonary stenosis. You will find, and also aortic regurg. So basically regurgitation of the valvular heart is extremely common among most of the connective tissue diseases. Now, the question here is regarding systemic sclerosis. Pulmonary hypertension is not surprising. Why is that? Because the disease itself, like any other connective tissue diseases, it's causing lung fibrosis and restrictive lung. So pulmonary hypertension is not that common to happen. If you look in all other options, the things might be obstacle to you is the option D, which is the aortic insufficiency. For some reason, the systemic sclerosis is the only connective tissue disease that I am aware it doesn't cause aortic insufficiency. But if you look in most of it, they cause a mitral valve regurgitation and aortic regurgitation. Option C, absolutely impossible to happen, but tricuspid regurg, yes, but not tricuspid stenosis. Next slide. Okay, this is from the Canadian Association of the Anesthesiologists guidelines, asking when in the intraoperative temperature monitoring is strongly recommended. Now, any surgery more than 30 minutes, it's recommending, whether you did it under general anesthesia or through regional anesthesia. Next slide. This is self-explanatory question, so it doesn't need that much of time to spend on it. For which of the following condition is the DVAB used to improve coagulation? Now, let's look to all options. Now, C and D, obviously, they are out of the, to answer it because they has no impact on the coagulation pathway of the system. So you're left with the chondroplasia and osteogenesis imperfecta. If you look at carefully, you will find the osteogenesis imperfecta. It's not that uncommon not to have a coagulation system. So DVAB is recommended whenever you start any surgery. Chondroplasia, there is some role of affecting the coagulation system, but it is extremely rare. Next slide. During a laparoscopic procedure on a healthy young patient, you suspect the development of the non-tension pneumothorax. Which of the following management option is most correct? Since the surgery, since the description of the question is non-tension pneumothorax, so i.e. a simple pneumothorax doesn't affecting the hemodynamic, so you can carry on the surgery unless, and you have to put multiple lines under the word of unless the patient became unstable. As long as the patient is stable, you can carry on the surgery without insertion a chest tube. Again, the trick of this question is non-tension pneumothorax. Next, please. Which of the following is a risk factor for hypoxia during one lung ventilation? This is a straightforward physiological question. So the answer is the vasodilator use. Left-sided surgery, low pre-op FE1, justice use of volatile anesthetic. Those are basically it's the opposite of the question. So the only right answer is the option D. Next, please. Which of the following is true about the DDFB? Again, this is a pharmacological question, basic pharmacology, asking about the mechanism of action of the DFB, which is act on vascular endothelial cells. It has nothing to deal with the synthesis of a vulnerable brand factor. It's actually hypotension rather than hypertension as a common side effect. Tachyphylaxis is quite common, so it's not rare. Next, please. A stable trauma patient is assessed after a high-speed motor vehicle collision. There is a stridor and subcutaneous emphysema. Which of the following management option is most appropriate? Now, if you're looking, if you read the question, this is, you have two clues in this question. Stridor and subcutaneous emphysema, which mean there is an airway trauma. So there is an air leak. So the most appropriate way of airway management here is through a guided FIGIN. So awake bronchoscopic intubation, or if there was a question, if there's an option of using the glidoscope or videoscope, will be also a correct. So why do you need awake bronchoscopic intubation? Because this is a potential difficult airway, and also you want a direct FIGIN to avoid a wrong pathway of skewing the airway. Next question. A 71 years old male undergoes robotic prostectomy in a steep tendon spring position. During the case, he developed increase in tidal CO2, which is responsible for the majority of this increase. Like any other robotic prostectomy, it's a long procedure. So an absorption of insufflated CO2 is not surprising. By the way, this is, and also because of the steep tendon spring position, that will promote more absorption of the CO2 coming from the abdomen, from the pelvis to the abdomen, migrated to the lung. Next slide. Regarding the fetal circulation, which statement is it true? Now, when say to you the question, which statement is it true, that means there's only one statement is true and the remaining is wrong. Option A is the answer, which is the blood flows from the right atrium to the left atrium through the foramen ovale. If you read it carefully, the option B and C and D, especially option B, might give you a hint that could be the right answer. Actually, it's the wrong answer, B, because it does not reduce, it's increased the pulmonary vascular resistance. Next, please. Which of the following is not a risk factor for post-operative FIGIN loss after spine surgery? Now, if you spine surgery with the FIGIN loss, there's a lot of causes of it. If one cause here was not being mentioned as an option to you, but number one is hypotension. So that's why hypotensive anesthesia in spine surgery is no longer recommended because of the post-operative FIGIN loss. Now, the second common cause of the post-operative FIGIN loss is excessive fluid given to the patient. And of course, if you're using a colloid, that means 3 times of the crystalloid administration. Next, please. Which of the following is a correct definition of the vital capacity? Again, this is a straightforward question. I think I'm guessing that it should be 100% score of this. This is a basic lung pulmonary physiology question. Next, please. Next, please. What if the following statement is true about non-steroidal administration? Again, this is basically a pharmacokinetic questions for the non-steroidal. Option B is the answer. They inhibit prostacyclin synthesis in the central and peripheral nervous system. Next, please. Which statement about Psychomedics pharmacology is false? Now, if you're looking carefully to option B, you will find that this is the only answer should be false, which is say bind both benzoylamines and aminosteroid. It does not. It just bind one of them only. Next, please. Which of the following is an echocardiographic finding of respective cardiomyopathy? Again, this is should be a very simple question. There's no way an answer more than B because it's self-explanatory. This is restrictive, so must be decreased in left ventricular filling. If you're looking ventricular contractility, it should increase. Ventricular size is decrease, and ventricular wall thickness also decrease. Next. Regarding the use of the ketamine for acute post-operative analgesia, which statement is false? It does not actually require large doses. In matter of fact, the dose is recommending anywhere between 10 to 20 milligram only. So option D obviously is a wrong answer. Next. Which airway muscles is innervated by the external branch of the superior laryngeal nerve? Again, simple anatomical questions, self-explanatory cricothyroid muscles. Next. A hip fracture ORF is performed under spinal anesthesia. There is a sudden onset of hypotension and the patient complains of chest pain. Which is the least likely cause? Again, if you look at it carefully, if it is total spinal anesthesia, the patient should lose his consciousness and he will never complain from chest pain because he lost his consciousness. So again, some of the questions, the answer is just right to you. But my always advice, when you answer MCQs, they say they are tricky. They're not tricky, actually. It's just a matter of understanding the question carefully. Next. Which beta blocker requires the greater dose reduction in renal failure? Again, this is a pharmacodynamic questions of the beta blocker. Atenolol is the right answer. Sorry, some of the question I'm not gonna spend time because as I said, those are fact. Those is basic science fact. They are self-explanatory, so they are fact. Next. Which statement is true about peripheral nerve injury after peripheral nerve block? Now, option C is the right answer, which is the peripheral nerve injury has the favorable prognosis for complete resolution within weeks to months of onset. So, some people, they think that this is required 6 months. I think this is where the time where they're doing the peripheral nerve block under paresthesia technique or blind technique. With the ultrasound, even if this has happened, they discover that the complete resolution happened within weeks, which is a good sign to the patient. Next. Which of the following drugs should be avoided in a post-liver transplant with a functioning graft? Of course, propranolol, because it has the first fat effect. It's solely through the liver, so we're trying to avoid it. Next. A patient has a myocardial ischemia with a TEE demonstrating involvement of the anterior 2/3 of the interventricular septum. What is the associated vascular territory? Again, this is a simple, straightforward anatomical question. The stem of the question looks so complicated, but it actually is so simple questions. It's talking about the left LAD, the left main artery. Next. Which of the following medications may precipitate carcinoid crisis in a patient with the carcinoid syndrome? Again, propofol is one of them. That's why the recommendation when you're giving a propofol, you never give a propofol fast because of the concern of the carcinoid crisis, especially if the patient, if you're dealing with a tumor cases. Next. Which of the following would be the strongest indication for replacing a magnet on an ICD? Again, ACT procedure is one of the strong recommendation to place a magnet in a patient with the, sorry, a patient with an ICD. Next. Regarding treatment of hypotension in a parturient, which of the following statement is true? Phenylephrine causes less fetal acidosis than ephedrine. That's quite true. That's why phenylephrine or neosynephrine, depending on the name that you are going with it, it's highly recommended nowadays in obstetric anesthesia rather than ephedrine. In matter of fact, there's a nice paper actually talking about avoiding hypotension after the spinal anesthesia is to start the patient on phenylephrine infusion or norepinephrine infusion, but to avoid ephedrine. Also, another problem with ephedrine, as you might also know, causing the fetal, just a fetal acidosis and also causing a maternal tachycardia. Next. Which of the following ventrami form the sciatic nerve? Again, this is a straightforward anatomical question, self-explanatory, SL45, S1, S2, S3. Next. Which of the following monitors cannot measure oxygen level? Again, this is simple equipment question, Dorsch and Dorsch. If you love to read that book, the dry book, the infrared spectrometry cannot measure the oxygen. Next. Next, please. A 52-year-old patient with a history of a heart transplant 3 months ago require ECT for refractory depression, anticipating his hemodynamic management. What medication will you have immediately available? Now, to answer this question, first of all, this is an innervated heart because the patient have a heart transplant. So you need a direct drug. So ismilol is the right drug that you needed to have it. Ephedrine, adenosine glycovaronate will never work in an innervated heart block. What you're expecting here is to have a tachycardia after after ECT procedure. Next. 60-year-old male with a COPD, diabetes, hypertension, has a planned lung tumor resection by thoracoscopy. Which of the following factors increase their risk of postoperative complication? Now, to answer this question, there is a nice table in Miller writing down all the predisposing factor for increasing postoperative ventilation and complication. And one of them, definitely a BCO2 more than 45 as a baseline. Next. An obstetrician has a difficulty extracting the placenta after a vaginal delivery. There is a uterine inversion accompanied by hypotension and bradycardia. what is the next immediate step in management? Basically, it's immediate manual replacement of the uterus. As long as the uterus is being inverted, the hypotension and the bradycardia will continue. Giving any medication, we're not going to help the situation. Always been advised. I remember with my time, my training, they told me that treat the condition, don't treat the number. So basically, don't look to the hypertension bradycardia. Look to the cause of the hypertension and the bradycardia. Next, please. You are taking care of a 3-year-old boy for inguinal hernia repair under GA. The patient developed ventricular tachycardia after the surgeon infiltrated 3 milligram per kg of bupivacaine into the wound. Which of the following is the most effective treatment? So the question here is giving 3 milligram per kg is very obvious, giving a toxic dose of the local anesthetic, although he's using an infiltrate technique of infiltrate, but a ventricular tachycardia, that's the clue for you that we are reaching local anesthetic toxicity. The treatment option always intralipid 20%. That's why the recommendation nowadays of the modern recovery room is to have intralipid 20% available in the recovery room, especially nowadays. The trend of anesthesia with the regional block has been increased dramatically. Next. According to the ATLS classification of the hemorrhagic shock, which percentage of blood loss correspond to class 3? Again, this is a straightforward question. Answer B is the right answer. Next. Drug elimination, half time is affected by all of the following except. Now, again, this is a basic pharmacokinetic questions in the pharmacology. The right answer here, all the option B, C, D is the correct. The wrong answer is the dose administered. Next. A patient is oxygenated with 100% FiO2 for 1 hour. Subsequently, there is an increase in the alveolar arterial gradient. The A gradient is increased. What is the most likely reason here? Most likely reason here, if you being giving the patient 100% FiO2 for more than 1 hour, you're just creating iatrogenic atelectasis through the absorption. So option B is the right answer. Next. You are asked to reassist a patient in PICU in recovery 3 hours after an eventual robotic radical prostectomy. What is the least likely complication? The least likely is the airway obstruction from macroglosia. And why is that? Because of the steep tenant ring position. So there is no way that this procedure will causing a macroglosia because all the fluid in the body will going downward rather than upward. Next, please. What is the strongest predictor for postoperative delirium? Again, if you're looking for all options actually, it's a predisposing factor for postoperative delirium. But read the question very carefully. Strongest predictor. Strongest predictor if the patient having before the surgery a pre-existing delirium. Next. Next, please. Which of the following is not a requirement for a demonstrating medical capacity? The answer here is again, if you're looking, all options are correct except B. So the B has not requirement for demonstrating a medical capacity. Next, please. 75-year-old patient with the IDDM, coronary artery disease, and functional class 1 angina is seen in a clinic prior to elective aneurysm repair. What test is the best predictor of cardiovascular complication and mortality? B&B nowadays has got the superiority than functional capacity, more than even the butamine stress echo. Again, read the question carefully. All those tests are being used as a predictor, but here is asking you the best predictor. Next, please. Regarding a neuromuscular blockade with a caesatracheum, which of the following is true? Again, this is a pharmacological question of caesatracheum. The duration of action is unchanged in liver failure because the caesatracheum is solely metabolized, excreted in the kidney. That's why it's number one option in liver transplant surgery or any patient with the liver failure. Next, please. A patient is receiving apneic oxygenation for a rigid bronchoscopy. Their baseline BaCO2 is 40. After 6 minutes, with the result. Okay, so this is a mathematical questions. We know that we have each minute how many BaCO2 will rise. Again, this is a solely pulmonary physiology questions. So you could make your mathematical calculation of the formula, but the answer is B, which is 60 milliequivalent. So in 6 minutes, you are increasing by 20 milliequivalent. Next. A pregnant patient at 30 weeks gestational age has a cardiac arrest. Which of the following modification or to ACLS management is correct? So the correct management here is to deliver the baby by 5 minutes after the starting resuscitation. So you can ask the obstetrician to perform cesarean section while you're doing a CPR. Next. For a patient at risk of aspiration, which of the following is true about cricoid pressure? It might be a surprising answer to you, but cricoid pressure has not been demonstrated to be effective. Next. Regarding laparoscopic cholecystectomy compared to open cholecystectomy, which is true? It's not surprising that the answer is A. There's a greater decrease in the glomerular filtration rate in those cases. Next. 7-year-old man presented for thoracic surgery. Which of the following parameters indicates high risk for postoperative pulmonary? Now, the 6-minute walk test is simple test. It doesn't require that much of equipment, very effective and very guiding to you that this patient at risk of postoperative pulmonary complication. Very simple test. I recommended everybody to do it to any patient, not even thoracic surgery, actually. Any patient that you would see him that he's at risk for pulmonary complication post-op. Next, please. Which of the following represent normal vital signs in a 1-month-old patient? Again, it depends if you're reading Schneider or Chestnut, you will find this question, find it in the table where displaying all the vital signs in different ages from 0 day to 1 week to 1 day to 1 month to 6 months to 1 year. Next. Are we done or what?
Yes, we finished the question, Dr. Osama.
Good, good. So I was, Dr. Awatif, I was looking, I was looking for the answers actually. If you allow me to make a comment to you,
Okay. Yeah.
sorry?
It's okay. You can comment.
Yeah, I think is just I'm trying to do analysis of the answers actually.
Mm.
It looks like people were not reading the question really very carefully to understand it. And this is the problem of the MCQ questions actually. There is an art of how to answer MCQ. Some people they answer it after reading first the option, then they read the question. Some people they spend time in reading the question. Some people they thinking there is a trick. A matter of fact, there's no tricks in any MCQs. The problem is the resident is thinking there is a trick. My advice again is to read the question very carefully and look what the question is asking, and be careful from those vocabulary being used from people who are writing the question. Sometimes they're writing the best, most, common, least. All these words, some um, stop and read it very, stop on it. That's number one. Number two, in any MCQ question, there is two answers. Take it from me. Very rarely you find only one answer available, but choose the most right answer. So you will find the stem of the question, especially if they're using four options. Take it granted from me, there is a two answers, but one of them is the most common answers.
Osama, I
Yes.
shared
Yeah.
the chat.
Yeah. Thank you so much. Thank you so much.
Yeah.
So now my advice to all of you, especially everybody knows his answer about each questions. Now, if ask yourself one question about the topic. So let's take for example the DDAFB question. The way when I trained myself about preparing myself for exam, for example, this is what I do, especially if I want to review all the questions. Okay, here's what I was doing to myself. Okay, the question now is asking about DDFB. Okay, so I close the paper and I start to talk with myself. What do I know about DDFB? Then I start to write down like an essay about DDFB to know I'm challenging myself about my knowledge. And after I did that, I go to the questions. If I answer it, that means this topic I don't need to go back and read it. But if I stuck with this scenario, I read the stem of the question and I found myself, I have no clue, that means there's no point to continue answering this question. What I need, I just put a remark from myself that this topic, I need to go and read it, and so on. That's my some advices to you, all you younger doctors. Good luck. Don't feel disappointed with this exam. Okay, just always look forward. And as I told you, all of you, you know yourself what your answer. You identify your weakness point and go from it. Dr. Awat, if I don't mind those questions to be shared among them, they can use it. But as I told you, don't study those questions. Study the topic of the questions. This is what you need to do.
Thank you, Dr. Osama, for this helpful session. Dr. Hadab is online. Dr. Hadab,
Yes.
you wish to...
أي
تفضل.
والله يا أخ ما أعرف أقول شنو بعد ده. أنا والله العظيم ممنون جدا لأسامة. يا ريت كنت أخترق وسائل التواصل دي، أمشي أقابله، لكن
دكتور
شاءت الصدف والكورونا إنه ما نتقابل.
لا دكتور هداب، احنا نتعلم منك، الله يصلحك.
الله يصلحك يا أخي. يا أخي شاكر جدا لما قدمته، يعني نحن متعودين منك، يعني عشان كده الأخوة اللي بيناتنا بتخلينا إحنا جاريين نتكلم معاك ونطلب منك في أي وقت.
لا والله بالعكس، انا مقصر معاكم المره هذه يعني.
والله نحن مقصرين، والله
أنا
كنا.
انت عارف اني انا من enjoying to do this. الوقت يمكن كان قصير لما طلبوا مني، وما كنت محتار يعني ايش اقدم. فلما قالوا لي في ناس يعني مقبولين على الامتحان، فقلت يعني يمكن شوية stimulation الأسئلة هذه لعل إن شاء الله يكون فيها نفع لهم بإذن الله تعالى.
إن شاء الله إن شاء الله. والله أنا I'm dead sure إنه يعني هي ذات stimulation بالنسبة لهم، وهي ذات دافع لإنه يشوفوا الويك بوينتس بتاعتهم ويتعلموا من التبس اللي اديتها لهم how to answer such questions. فشاكر وممنون.
الله يعطيكم العافية. في أي أحد ما أعرف والله إذا بالشات في أحد حط أسئلة ولا حد عنده مداخلة؟ أعتقد إن we have another 13 يعني. فدكتور عواطف إذا في أحد عنده سؤال ولا شيء.
somebody on the chat بس بيقول لك ممتنين وربنا يديك العافية وكتر خيرك.
الله يعطيه العافية.
الله يعافيك. بس أنا عندي كومنت أخير، إنه الطريقة اللي أنت قلتها حقت الدراسة دي this is the right way for studying anesthesia. You read questions and you have to read the topic of the question, not the question in per se، لأنه the question might change، ممكن يتغير السؤال، لكن المعلومة اللي أنت بتاخدها من السؤال هي اللي ما بتتغير. ف every time you answer the question straightforward, you just go for the next question. But if you have a problem with the topic of the question, you have to highlight that so you can go back to that question again. يعني في حتت انت بتكتشف فيها نقاط ضعفك، فدي لازم every time انت تعمل عليها علامات على اساس انه when you revise you have to revise the markings, not to revise all the topics. تمام؟ وربنا يوفقكم ان شاء الله. شكرا دكتور أسامة وشكرا دكتور هداب.
طيب دكتور عواطف، يعني مثل ما قلت لكم يعني أنا I don't mind if you want to schedule myself for another time. إذا في topic أنا صراحة يعني أحب إنكم تسهلوها علي، إنكم تختاروا التوبك لي.
أيوة إحنا إن شاء الله that's what we'll do. صح. أوكي حاضر.
الله يعطيكم العافية. شكرا جزيلا.
شكرا جزيلا. شكرا.
أيه.
يعطيك العافية. مع السلامة.